Hi, and thank you so much for joining me today. My name is Mike Ast from Hospital for Special Surgery in New York City. I want to give a thank you to Becker's for allowing me to speak today, and as well say thank you to Ortholine for hosting this event. Today we're going to talk about technology in the ambulatory surgery center and a little bit about why efficiency matters. And we're going to spend this particular time talking specifically about joint replacement surgery in the ASC. I have some disclosures. One important and relevant one is that I am a consultant and a designer for Ortholine, and I do consulting for several other companies in the ASC space. So I think when we talk about joint replacement in the ambulatory surgery center setting, it's always helpful to take a look back and say, where were we? Then a little bit of a look at sort of life as it is today. Where are we? Sort of what's the volume of surgeries look like? What are some of the protocols look like? And then I'd like to take some time, since it's the topic of this talk, to talk a little bit about the technology we're using. And for this, I'm going to stick mostly to surgical technology. So what does our enabling technology for surgery centers look like today? And then where we are going? Like, where is this technology able to take us, and what do we need to be doing in the near term and the future to be able to handle what is likely to be the increasing volume we're going to see of joint replacements in ambulatory surgery centers? So where were we? Where did this all start? Well, there's been a long history of joint replacements in the ambulatory surgery center. They've been performed since the very early 2000s, and Rich Berger out of Chicago has been publishing data for almost 15 or 20 years on the success of ambulatory joint replacements. Over the last 10 to 15 years, there have been multiple studies looking at the safety of ambulatory surgery center arthroplasty with very, very good results, showing both minimal complications as well as comparable or even improved clinical outcomes for joint replacements done in an outpatient setting. And there's a couple of ways that people define outpatient, and whether it's sort of the Medicare definition of a less than 24-hour or 23-hour stay that could or could not involve an overnight stay, or you talk about the true ambulatory setting where the patient is discharged on the same day of surgery, either from a hospital, specialty hospital, or ambulatory surgical center. I think either way, the theme of this is that earlier discharges from surgery after having a hip or a knee replacement is not something new. It's almost 20 years old, and almost every study done has shown very positive outcomes. And we know that the outcomes are not just positive on the clinical side, but there are certainly economic considerations and economic benefits for the use of outpatient facilities to do joint replacement surgery. 5 years ago, maybe even 10 years ago, we were at the period of very early interest, where we were seeing select centers throughout the United States doing these types of surgeries, but it wasn't very common. Over the last 5 years, I think we've seen the biggest and most rapid growth of this type of surgery, and mostly because we've seen the development of more specialized protocols for perioperative care, for how do we take care of these patients, for how do we create a reproducible situation where the patients are going to have a positive outcome, and we're going to minimize any risks that might be associated with shorter stays or quicker discharges. And further, we've had a lot of work done on patient selection, because like we know, not any one thing is perfect for every single patient. How I like to always think about this is you want the right patient in the right side of service at the right time, and developing both strong protocols and appropriate methods for patient selection really help to strengthen our ability to do this safely and to be able to provide predictable outcomes. And once that started and you really got into the growth where people were more interested in this and they thought that this could be moved outside of some of these early specialty centers, you started to see a lot of outpatient centers, specialty hospitals, and even general hospitals start to understand the logistics associated with a higher throughput as well as a shorter length of stay within that facility. Here's a picture actually of my old surgery center, and this is probably from about 2012 or 2013. You can see over on the left side of the screen, that's Elise, my surgical tech, and that's my PA on the right side. And you can see this is not a very big or advanced facility, right? It's about a 400 square foot room, sort of an older facility. And this is like most ambulatory surgery centers in the United States. It was originally designed to do hand surgery, sports medicine, interventional physiatry. And so there are limitations when you compare this type of an operating room to the ones that we normally do higher acuity cases like joint replacements. And as you start to look deeper into trying to take one of these older centers and move it to more higher acuity surgical cases like joint replacements, you realize there are just some things that are challenges, mostly related to infrastructure. Surgery centers often just aren't prepared for joint replacements. They don't have the sterilization capacity. Perhaps they don't have the right equipment or power tools. They're used to having patients in and out of that place in an hour, so they don't really have beds for longer recoveries, especially if you're looking at surgeons or anesthesiologists using a spinal anesthetic where a patient is kind of just lying there numb for a few hours. It's really hard if they're doing it on potentially an uncomfortable stretcher that might have some pressure points. They may not have helmets or other types of protective equipment that we're used to seeing when we do joint replacements. And realistically, they may not even have the basic surgical tools for larger cases. Again, it's a very different set of basic surgical tools to do arthroscopy and hand surgery and foot and ankle surgery than to do something like joint replacement surgery. And so these challenges only started to show up as we started to see more centers in more places starting to take on these types of cases. The number one limitation that we really see in these centers is sterilization. Sterilization is both an earlier and a late limiting factor in the ability to do more cases and to be able to get more patients through, certainly an ambulatory surgery center. And because of that, as we've learned what the logistical challenges can be, we really learned to focus that limiting your trays and understanding ways to improve your supply chain are necessary to achieve scalability and success. So as you start to think to the topic of this whole conversation, to technology we can use in the operating room, we really want to not just focus on clinical outcomes, because clinical outcomes are obviously very, very important, but they are not the only consideration when trying to make this site of service transition and start to bring things like joint replacement surgeries out into the ambulatory surgery center. So where are we now? Sort of, what does it look like today? Well, today, one of the nice things is we've got a lot of these mature protocols, and that's probably what's driven that, recent 5-6 year quick and large growth of these types of programs. We've got mature protocols for patient selection, for blood management, for fluid management, and for pain control. I'm sure there's going to be a lot of talks at this conference about pain control, so I'm not going to spend much time on that. I think it's really wonderful to see the advances we've been able to make over the last 10 to 15 years with the adoption of true multimodal pain management programs through opioid avoidance, as well as through the understanding of nerve blocks, local anesthetics, long-acting anesthetics, and the relationship between different types of pain medication and their ability to make patients much more comfortable after these surgeries to allow for quicker mobilization and quicker discharge. But I do want to spend just a couple seconds talking about some of the other protocols, because often when people ask kind of what's the real key to getting patients out of an ambulatory surgery center safely and reproducibly, we're so good at pain now that doesn't seem to be the challenge. And the challenge really lies in patient selection, blood management, and fluid management. So taking a few seconds to talk about that and make sure that, since you're probably going to hear it several times throughout this conference, it's really getting drilled home some of the things that we think are important can be helpful. There's a few ways to look at patient selection. You can kind of make it as complicated or as simple as you want. I think what you really want to do is learn who to stay away from. Who are the high-risk patients? Who are the ones who have a higher chance of a poor outcome, or you really just want to keep out of your ambulatory surgery center entirely? I think untreated or unrecognized sleep apnea is a very important one. Just the presence of sleep apnea alone may not necessarily be a problem, but if somebody has sleep apnea they don't know about, it's not being treated, it's very important to keep them in the hospital or keep them in a center overnight on O2 monitoring, as data has suggested these patients have a much higher risk of complications within the first 24 hours. Preoperative anemia is certainly something to be thought about if you're going to an ambulatory surgery center, as most centers do not have the capability of doing blood transfusions. And so you really need to make sure these patients aren't going to need a transfusion. We'll talk a little bit about some of the other things you can do about blood management in a second, but the recognition of preoperative anemia and keeping those patients out of the surgery center or potentially even out of the operating room until they've undergone some type of preoperative blood management program is probably appropriate. Morbid obesity is often discussed, but potentially not an absolute contraindication. I think like many things in medicine, morbid obesity doesn't exist in a vacuum, and understanding the comorbidities associated with morbid obesity is probably more important than simply using a BMI cutoff in a surgery center. That being said, you do want to keep very, very obese patients out of the surgery center and in the hospital where there's some backup, especially as the BMIs go above 50 or beyond, due to the increased risk of cardiovascular complications associated with these patients. And one thing that I think it took a long time for us to understand is the understanding of the social situation of the patient and the home support. And I'm going to talk about that in just a minute. You also want highly motivated patients, as these patients are going to need to be up and walking and moving right away, and patients who are fully, quote, medically optimized, whatever that means to each individual surgeon. But you really want to make sure that any of their comorbidities are in the best shape possible when you're going to put them through this surgery and give them the best chance of a great outcome. Now, you can certainly get more complicated and utilize some of the scores that are out there. This is Dr. Mangini's score at IU Health in Indiana, where he's created a very reproducible and very intense patient selection criteria that has been validated by multiple studies and shown to be very effective at, from a medical standpoint, predicting a patient's ability to safely be discharged on the same day of surgery. If you've never seen it or never been aware of it, take a look at it. It is a very interesting assessment tool and very, very useful tool for patient selection. The other thing you really want to think about, and one of the other things we have found, and we did this in a partnership with our friends down at the Rothman Institute, was starting to understand the social factors associated with patient discharge. Because it's not just about, are they healthy enough to go home on the same day, but are they going home to an environment that's going to be conducive to them going home, recovering safely, and staying home. And we were able to identify some very specific risk factors for patients not being discharged on the same day of surgery. And these are things like having more than 3 flights of stairs, living by themselves, or being the primary caretaker of another human being, whether this is a child, a spouse, or partner, or significant other, or even a friend or a parent. If they're going home to take care of someone else, potentially they're not taking care of themselves. And so these patients probably do better when kept overnight in a facility, whether that's an ambulatory surgery center with overnight capacity or a hospital or a specialty hospital. Just something to think about. And as we look more and more towards really trying to make sure we're getting the ideal patients and not putting any patient at an increased risk, you want to start thinking about some of these social factors that really make a difference. You also want to try to avoid patients on chronic pain medication, as they've been shown to have higher rates of revisits to the ER or readmissions due to pain. Blood management is another really important protocol that needs to be in place at any surgical center. The recognition and judicious screening for preoperative anemia, making sure that patients who are anemic pre-op, especially if the hemoglobin is less than 11, you want to keep those patients out of the surgery center as they're at an increased risk of postoperative blood transfusion. But realistically, in many cases, those patients should actually be sent to a hematologist, worked up ahead of time, and probably put into a program of preoperative blood optimization and even consideration of the use of erythropoietin to try to get them to a better place, because we know that postoperative transfusion is an independent risk factor for multiple complications. And so if you can find a way to avoid that, that's probably safer. And then anyone not using tranexamic acid at this point should really consider doing so. How you dispense it really doesn't matter. There haven't seemed to be any major contraindications that we can find or any risks associated even in many of the sicker patients if you look at the data out of the Mayo Clinic. And not only does this decrease blood loss and decrease the risk of blood transfusion, it also seems to improve the physiologic response to physical therapy and has been associated with improved postoperative pain and improved function. So the use of tranexamic acid in basically all comers, especially if they are medical candidates for an ambulatory surgery center, should really be stressed in every single case. And one of the last things that people are starting to learn more and more about is fluid management. I think the American Society of Regional Anesthesia did a really nice job in some of their more recent recommendations in regards to how to treat perioperative fluid management for ambulatory cases and for joint replacement cases in general. You want to keep patients at a fluid level that helps them avoid nausea, vomiting, and lightheadedness. If you look back at the data for ambulatory joint replacement over the last 15 or 20 years, almost all patients who failed to be discharged on the same day of surgery failed because of nausea, vomiting, and lightheadedness or dizziness when they stood up to mobilize. Keeping patients at an appropriate level of fluid management can really avoid these complications. We have a fairly aggressive fluid management protocol in our institution and in many institutions that I've worked with. Patients should be NPO of solid food from the night before, but only 2 hours NPO of clear liquids. We actually encourage our patients to drink a bottle of a sports drink or clear water prior to surgery. We ask them to stay away from blue and red. Blue makes you look cyanotic and red makes you look like you have blood in your mouth. So we want to stay away from those. And to avoid that, we actually give our patients a bottle of yellow sports drink. But you can certainly use clear liquids, clear water, especially for diabetic patients. But you do want them to drink, and we tell them to drink it on the way into the surgery center or hospital that morning. We also give them bottle to drink the night before they go to bed. During surgery, we keep patients essentially euvolemic. We try not to kind of do too much fluid or too little fluid. We obviously don't want to increase bleeding or just increase visualization issues, but at the same time, we're really trying to keep them from becoming hypovolemic. And then after they void, once they're up and moving, we actually will bolus them with usually 1 liter of fluid, again, just to make sure we're keeping them hydrated. It helps them ambulate, it helps them not be so dizzy, and it helps with the nausea that can really bother people. And this has been one of the most important changes we've made over the last 5 years to predictably be able to discharge patients early after surgery. And I think some people ask kind of what is the most important thing that people don't think about? It would be fluid management. I think fluid management is something that we as surgeons, as orthopedic elective surgeons, just never really thought of that much. I think the trauma surgeons have done a better job over time thinking about it, but they have very different goals. And so when we're talking about trying to get patients to predictably be able to leave on the day of surgery, fluid management is a very important thing, and I encourage any surgeon, nurse, coordinator, or anyone else to really have a good discussion with the anesthesia team to understand the safest way to appropriately hydrate patients so that they're able to get up and participate with their therapy afterwards and get moving after the surgery. And when you have all of these changes in protocols and you develop these stronger protocols and these better protocols for moving forward with these types of surgeries, you see these types of trends. So this came from the Ambulatory Surgery Center of America journal a couple of years ago, and basically showed the predictive forecasts over the next couple of years for what this trend is going to continue to look like. And we can see that while you watch the volume of joint replacements going up over time, the volume of inpatient joint replacements is actually going down a little bit. And the volume of outpatient joint replacements is skyrocketing. And I think this is going to be probably moved even more dramatically by the COVID pandemic as patients begin to be a little more leery of going to or staying in hospitals. The concept of being able to social distance and the safety of being at home, I think, is going to drive this transition even a little more. You know, I've talked to many people over the last couple of months in thinking about what the world has been through since March. And if you think about it, I've been doing outpatient arthroplasty for about 6 years now, or maybe a little longer. And in the beginning, a lot of it was driven by me. I thought it was safer for patients. I liked it better. I liked the control I had at the surgery center. And patients went along with it because they thought it was a good idea. They liked it. They had a friend or family member who had gone through it and they were on board. I find that it's actually different now. Now patients are really the ones coming in and driving it, saying, hey, is there any way I could get out of the hospital? I just want to be home, but I want to get the surgery done. Can I just go home on the same day of surgery? Can we just stay, at a specialty hospital or surgery center? And it's very interesting to see that the sort of this terrible pandemic that's affected our world has really also had a unique impact on the world of outpatient arthroplasty and potentially accelerated this trend even beyond what we were expecting. And all of that brings together the importance of all the things we're talking about today, whether it's having established protocols, whether it's making sure you've got the right patient selection, or whether it's the types of technology decisions that everyone's going to need to be making to be able to make this transition safe, reliable, and efficient for everyone involved. And CMS is certainly doing its part to move along as well. Many of you, I'm sure everybody who's at this conference is aware of this, came out last week, where they're talking about the 2021 prospective payment system. They're talking about an increase in payments for ambulatory surgery centers, as well as moving total hip replacements onto the ambulatory surgery center approved list. I think this is just another one of the many things that's going to push this field forward and accelerate the transition of joint replacements out of the traditional inpatient hospital setting and into the outpatient hospital setting, and whether that's done in a hospital outpatient department, whether that's done in a specialty hospital, or whether that's done in an ambulatory surgery center. I think everything around us is sort of creating that perfect storm that's really pushing us in the direction as to why we're all at conferences like this and doing research on these topics and trying to understand how we can maintain the perfect level of safety, the optimum level of surgical success, and at the same time carefully navigate this freight train of a transition that we're all going through at this time. So with all of that as kind of the background and the basics of everything we all need to know in terms of transitioning from an inpatient world to an outpatient world, let's take a look at some of the things that technology can add here. What about our surgery could we do better, more efficiently, more appropriately, and how can technology help us? I think when we talk about answering the challenges we see in the ambulatory setting, there's a couple of them. The first is reproducibility, right? You really need to make sure you're able to reproducibly get through the surgery every time, because the margin of error within a surgery center is even smaller than the margin of error in a hospital. As we know, many times in hospitals, there's a lot of backup equipment, there's extra trays, there's extra sets, but also the patients who are coming to our surgery center are patients with a higher level of expectations, often healthier, younger, higher activity levels, and reproducibility not only in getting from point A to point B in the surgery, but also in providing them that highest level of outcome so they can do the things they want to do become even more important in the ambulatory setting when you compare it to the inpatient setting. Efficiency is key. As we saw from those market trends, the number of joint replacements we're going to do in the outpatient setting isn't going down. It's likely to continue to go up, and we need to find ways that we can make us all more efficient. If we look back to probably one of the most quoted articles in the joint replacement literature, the Steve Kurtz article on the sort of predictive volume of joint replacement surgery from now until maybe a decade from now, we're talking about 6-fold increases in surgery. We're not getting 6 times as many surgeons, so we're all going to have to figure out ways that we can take the same amount of time in the day, the same amount of resources across the care team, be it the anesthesiologists, the therapists, the surgeons, the surgical staff, the nursing teams, everyone involved. How are you going to get the same amount of people to do more volume? And that's going to be the efficiency side. And then the supply chain side, because supply chain and sterilization are even more critical aspects of growth of a program in an ambulatory surgery center, because like we talked about, this isn't the type of surgery they were originally done for. So when evaluating any technology for its use in the surgery center, it's very important to understand not only is it going to give you reproducible outcomes, not only is it going to make you efficient, but how's it going to affect your supply chain and sterilization issues? Because if it can benefit all three of those things, then you know you found the right technology answer for you. And I think there's a lot out there, and everyone's going to have the particular technology that works best for them. I just think it's very unlikely there's going to be much done without technology in the future, as we can't simply make ourselves better, stronger, faster without the help of some of our enabling technologies. And the most popular and common technologies being used today are PatientMatch technologies, or what some people will refer to as patient-specific instrumentation. There are robotics, which is obviously a very hot topic right now, and there's multiple types of robotics, and sort of not all robotics is created equal. So something that if you're really thinking about investing in or looking in, you want to take a really good look at what's a robot, and what's a robot. And then there's handheld navigation technology, and we're going to spend a little bit of time specifically talking about that one, because it has a pretty nice, unique little place in the ambulatory surgery center world, although it's used in hospitals and inpatient settings all over the world. Also, because Ortholine was nice enough to host this, this should give a little insight into their technology, what it offers, and how it might be the right answer for your surgery center or surgery centers and outpatient centers out there. PatientMatch Technology uses advanced imaging to create custom instrumentation, and this can go everywhere from just creating some cutting guides to even manufacturers and companies out there that create custom implants. And some of the really nice advantages of this are it does decrease the case duration dramatically by eliminating about 20 to 22 steps from a knee replacement. There is also PatientMatch technology available for hip replacements. It does not have as much clinical data behind it, but there's plenty of clinical data to show that PatientMatch technology can create efficient and reproducible outcomes. And this may be something that surgery centers want to take a look at, or surgeons want to take a look at if they're trying to see what technology may help them. It's certainly very good for knee replacements in terms of sizing and femoral rotation, and also good at, like I said, just kind of streamlining the steps, controlling that supply chain, and controlling that sterilization by minimizing the number of trays needed. Robotics, again, we alluded to before, very, very hot topic right now. A lot of different types of robotics. There's, robotic arm assisted, there's without the robotic arm. Some require advanced imaging, some do not. Some are robotically assisted cutting guides, but aren't actual robots, as the definition of a robot actually means that there is an end effector being used. So if it's just placing a cutting guide, that would be considered a robotic cutting guide, not actually a robot. But there are several of each of those out there, again, all with quite good data behind them. They tend to be very good at alignment, balance, position of implants. Most of them are closed platform systems, meaning you buy this robot to work with this implant. And that can be a limitation at times if you've got multiple surgeons or multiple people who are trying to use the same technology, but maybe don't use the same implants. And often these are associated with capital expenses, which may be appropriate in some surgery centers and inappropriate in others, but certainly is a consideration when thinking about something like robotics, if that becomes your technology of choice for your ambulatory surgery center. Handheld navigation, in this case, the Ortholine system, is really a uniquely positioned system for surgery centers, especially for those just starting into their growth phase. There is no capital expense for a system like this. It is open platform, so it can be used with any implant at all. It has excellent clinical results that we'll go over in just a minute. There's no arrays or line of sight issues. It is not like traditional navigation that requires an optical camera or trackers. It has minimal trays and disposables, so it does achieve some of those other setup, sterilization, and supply chain issues. And it is available for partial knee replacements, full knee replacements, and total hip replacements as well. And all of that is within the same system, so it's the same unit that can do all of those different things. So when we talk about handheld navigation or smart tool technology, we can first look at the reproducibility efficiency side of it, and we'll start on the knee. So the nice thing about the Ortholine system is it really does check a lot of the boxes. It is very accurate. There have been over 100,000 cases. There's over 18 clinical studies showing incredible levels of accuracy. It can be used anywhere. It is a single-use disposable instrument that can be used for any surgical technique, any surgical approach. You can do a partial knee and simply change right over to a full knee if you'd like. It's got a gap balancer and rotational guide that you can use to make sure you're getting your ligament balancing correct. You can make sure you're getting your femoral rotation correct. So it can check all of the boxes that any of the other technologies have. Again, like I said, there's no capital cost, no software upgrades. Every single time you get the box is the newest box that exists. And it does not require any type of advanced imaging or advanced planning. The other thing with some of, is that's another advantage with some technologies, it does require some advanced planning. This system does not, which could potentially be helpful for people trying to move through a little more quickly. It is implant and approach agnostic. It is philosophy agnostic, meaning if you're a knee replacement surgeon that believes in a mechanical alignment, a little bit of a hazy mechanical alignment, kinematic alignment, whether you're a gap balancer or a measured resection surgeon, none of that really matters in the idea that this technology will adopt any philosophy you decide to use. The clinical results have now been published for almost 10 years. Most of them were done by a very good friend of mine, Dennis Nam, now at Rush. He and I were fellows together at HSS many years ago. He's published multiple studies on this in terms of the accuracy of the tibial, coronal, and sagittal alignment. You can see here when compared to an extramedullary guide, a handheld navigation system is dramatically more accurate when it comes to achieving clinical accuracy. The same thing on the femoral side. In this case, the comparator was standard large console navigation systems. You can see that handheld navigation is more accurate than standard traditional navigation, and those are both much more accurate than intramedullary guides that are most commonly used in the femur. Also, the advantage of all of these technologies, especially in the surgery center, is not violating the intramedullary canal, not needing to put a rod up the femur, which has been associated with increased pain and increased blood loss, two things you definitely want to stay away from when trying to discharge a patient 6 hours after surgery. So you can see here that is another advantage. And the overall results, if you look at overall limb alignment in knee replacement using handheld navigation, you can see it's actually dramatically better than standard navigation, and this did achieve statistical significance as well as clinical significance in this study, where you see over 93% accuracy for overall limb alignment within 2 degrees. Some other improvements when systems were compared in terms of other surgical parameters, you can see that blood loss was statistically lower using this type of navigation system when compared to intramedullary guides, and the tourniquet time was also less when you compared this navigation to other forms of navigation. So like we said, it's not just about making sure you get your clinical outcomes accurate, it's about making sure you're decreasing risk of complications, decreasing blood loss, and trying to improve efficiency along the spectrum of care, and this system has published data to support each of these outcomes. One of the newer and nicer features I like is the addition of the gap balancing system to the Ortholine system. This allows for control of your gaps on both flexion and extension, as well as control of femoral rotation. This is kind of what the system looks like. And again, it is completely implant agnostic, but allows you to take into account the soft tissues within your knee when making your clinical decision making. It gives you information much like we're used to getting from advanced navigation and robotics. It gives you your medial and lateral gap heights, total gap heights, as well as rotation for your femoral component. And for those looking to really get that next level of information from your technology, you can see that this isn't a simplified version of anything. This is the same level of technology and the same level of information you can get, simply in a different system. The other nice thing is it's not limited just to the knee. There's very good data on the hip, and we know the problem with hip replacements is we're simply not as good as we think we are. The Lewinick safe zone, for what it's worth, is just a target. I don't actually think it's a very good target, but it is a target nonetheless. And when used at the target, we only achieve that target about 60% of the time. Now, when we talk about using advanced enabling technologies like handheld navigation, you can see that we can achieve a whole lot more than 60% accuracy. And I think most of us believe that both short and long-term clinical success of hip replacements is related to accuracy of implant placement. And you can see for both abduction and anteversion, significantly better results when you're using some type of enabling technology. And this specifically in yellow, you can see the handheld navigation system from Ortholine showing very, very high levels of accuracy for component position and hip replacements. When compared to using fluoro, if you're talking about a direct anterior hip replacement, again, it's not really about what is your target so much as you want to be able to hit your target every single time. This is an article, this is a paper by Ben Dome, where basically they looked at their fluoro results and their results using, and then it was compared to the surgical technique associated with handheld navigation. And you can see a much tighter control of those surgical variables and a better chance to hit that target when using this and comparing it to fluoroscopy. So many people say, well, maybe I don't need technology because I'm using fluoroscopy. You can see that this type of handheld navigation technology is actually much more accurate than fluoroscopy, even in the direct anterior approach. This is kind of what it looks like across the board when you look at robotic assisted versus handheld navigation in the middle versus fluoroscopy. Off on the right in green, you can see the highest level of accuracy was associated with handheld navigation. And fluoro times were also statistically lower when using navigation. And for those of us thinking about the longevity of our careers and trying to avoid, being the surgeon or healthcare worker or surgical team member who gets sick over time, decreasing my exposure to radiation and fluoroscopy is also something I like to do. And seeing that the use of enabling technology can help me dramatically decrease fluoro time is always a good thing in my mind. Secondarily, like I said, we can't just look at the surgical outcomes because clinical variables are only half the story. We really want to look at supply chain and sterilization. And again, the major limiting factor for the ambulatory surgery center is the sterilization capacity. And having fewer trays not only improves the time in the OR, but it also decreases the costs associated with sterilizing these trays and doesn't stress out central processing so much, because at a hospital with a large central processing system, there's a lot more slack in the system. I always joke that in my original surgery center in 2013, our central sterile processing, his name was Marcus. It was just one guy. He was doing all of the work. And if we were trying to give him multiple trays to process, it just wasn't going to work. What you need to try to do is take systems that look like this. We have 5, 6, 7, 8 trays, and figure out ways to create a system like this. So this is my standard knee replacement setup in the operating room. It is 4 very simple, very light trays on a single back table. We can do the entire surgery with just this. This works well for my hospital. This works well for a surgery center. This works well in any sterilization setup, as it's really only 4 trays. And you can see some of them aren't even packed that tightly. At times we've gone down into half trays when we needed it. And many of the implant vendors will also help you with this, but having the appropriate enabling technology really allows you to limit instruments to only what you're going to need and decrease the stress on the sterilization capacity of your surgery center. So in conclusion, I just don't think there's any question anymore. Outpatient is going to be the largest growth area of joint replacement. It is right now, and it's going to continue in that direction. Technology is going to be very, very important in optimizing logistics and maintaining the optimal outcomes for our patients, because both of those are going to be very important. We can't do anything that hurts the outcomes or safety of our patients, but we can't ignore the importance of the logistics associated with this transition in site of service. It's going to be more patients. going to different centers that may not have as much experience in these surgeries, and we need to understand the technology available to us that's going to let us achieve these goals while keeping patients safe and moving these centers through this transition in a way that doesn't overwhelm them. And continued improvements in all of those things, but especially the technology we're using to achieve these goals, is going to benefit every stakeholder: the patient, the provider, the payer, as well as the healthcare system in general, as this volume of outpatient arthroplasty grows. And with that, I'd like to thank you so much for your time. Again, thank you to Becker's for the opportunity to speak, and thank you to Ortholine for hosting this session. If there's ever any questions in the future, I'm hoping they'll make my contact information available. And again, thank you so much for your attention.